Welcome to today's webinar entitled When TB is the Least of Their Worries, TB and Immigration, sponsored by the Southeastern National TB Center. Today's speaker is Drew Posey. Dr. Drew Posey is the Medical Assessment and Policy Team Leader in the Immigration, Refugee, and Migrant Health branch at the Centers for Disease Control and Prevention. The native of Marietta, Georgia, Dr. Posey earned his medical degree at Mercer University in Macon, Georgia, and completed a residency in family practice at Floyd Medical Center in Rome, Georgia. Following residency, Dr. Posey joined the CDC as an Epidemic Intelligence Service Officer. Dr. Posey's current position involves overseeing the implementation of regulations that govern the required medical examination for immigration and working on global tuberculosis control efforts. Today's moderator is Dr. Connie Haley. Connie is an infectious diseases physician trained at Vanderbilt University. She has worked in TB since 2001 and now works as a medical consultant for the SNTC. Now we'll turn it over to our presenter, Dr. Posey.
Hello, everyone. This is Drew Posey. I just want to double check y'all can hear me.
We can hear you.
Fantastic. Well, thank you very much for the opportunity to present in this webinar. Really excited about it and hope we can provide some great information and then answer some great questions once we are done. All right. So let's get started. Through this presentation, you will hopefully learn a lot about U.S.-bound immigrants and refugees, how they are screened for tuberculosis to help inform follow-up evaluations and treatment after arrival to the United States, understand the effect of this screening program on U.S. tuberculosis efforts to decrease community transmission of Mycobacterium tuberculosis and prevent individual morbidity and mortality, and learn about how information from the overseas exam is transmitted to the receiving health departments and why this is important to ensure patients are adequately managed and enable evaluation of screening data for quality improvement and measuring outcomes. So we are going to cover a lot of ground over this session that will hopefully give you a big picture overview of our screening program, provide some real-world information and data on some of the successes we've had that hopefully are very tangible for you, for everyone stateside, as well as give information on how all that information from overseas reaches you stateside. First, let's talk about some definitions. For us in our group, we go by, U.S. law legal definitions of these different populations. So let's review them for just a second. An immigrant, those are people who officially apply for and obtain U.S. immigrant visas overseas and will become lawful permanent residents upon arrival to the United States. Their full exam is done overseas by what are called panel physicians. They can then apply to become a U.S. citizen after they have been a lawful permanent resident for 5 years. Refugees, they are not LPRs yet when they arrive to the United States, unlike immigrants. They are here under a protected status. They are required to apply for adjustment of status after they've been in the United States for at least 1 year. Then they can apply to become a lawful permanent resident, and most of their examination is completed overseas. Status adjusters. These are persons applying for lawful permanent resident status while they are already in the United States. They must go through the full medical screening exam, but it is done by a civil surgeon. And just like with persons who arrive on an immigrant visa, after 5 years in the United States as a lawful permanent resident, they can apply to become a U.S. citizen. The medical examination and the technical instructions can only screen for conditions relevant to U.S. immigration law. It is not a complete medical evaluation. And just as a reminder, if this has been confusing, don't worry. We in our office who deal with this all the time have to check ourselves also. Becoming a U.S. citizen is naturalization, not adjustment of status, and there is no medical exam for becoming a U.S. citizen. Okay, we're a unique group within CDC and the Division of Global Migration and Quarantine in that we have some regulatory authorities we'll talk about in a second, but we also are in a public health agency, and so we have a public health mission, which is to reduce morbidity and mortality among immigrants, refugees, travelers, expatriates, and other globally mobile populations, and to prevent the introduction, transmission, and spread of communicable diseases through regulation, science, research, preparedness, and response. So let's go over some of the regulatory authorities we have. We're going to briefly mention some because they tie into things that we do in our program and that you see happen behind the scenes. So there's something called the Immigration and Nationality Act of 1968. It establishes that there is a required medical exam. Granted, the United States historically has had a medical exam in its immigration process, if we think back to the classic Ellis Island days, but this particular act governs things we do today. There is an exam. It talks about that there are what are called inadmissible conditions, and through our regulations, those are defined as tuberculosis, which is actually active TB, Hansen's disease, two sexually transmitted infections, gonorrhea and syphilis, and then there's a mental health component looking at harmful behavior related to physical or mental conditions someone may have, and drug abuse. And there's a vaccine component for immigrants, but not for refugees. The Refugee Act of 1980 gave us expanded authorities to try to prevent and control infectious diseases overseas at the origin. It also has language in it regarding notifying state and local health departments of information from the overseas medical exam. And then finally, there are the federal quarantine regulations in existence since the country was very, very young, which deal with helping keep bad diseases from entering the United States in general and crossing international and interstate boundaries. Okay, so how many people are we talking about? As we know, the United States is a large destination country. In fiscal year 2017, we resettled 54,000 refugees, and there were 1.1 million immigrants. These are the lawful permanent residents that we referred to a minute ago. Roughly half of these completed the immigration process overseas and got an immigrant visa, whereas the other half are those folks we call status adjusters who are living in the United States on some type of legal status, typically the bottom grouping, international workers or students, and then apply to be a lawful permanent resident. And then you see we have several million others, workers, students, their families, or tourists enter the United States each year. As we start to zero in on tuberculosis, I think this audience is very well familiar with this slide produced by the Division of TB Elimination, showing the increasing proportion of TB cases for many years now among the foreign-born. This really highlights the importance of our efforts to try to do things for tuberculosis in populations entering the United States. This is a map produced by the World Health Organization showing incidence rates of tuberculosis around the world. And I think we can all appreciate on this particular map, the darker the shading of green, the more tuberculosis there is, and that we get a lot of people coming to the United States that happen to be from the greener areas, again underscoring the importance of our efforts to try to do what we can regarding tuberculosis overseas before entry. So I've got what we hope is an interesting slide here for you. We do a lot of work behind the scenes with our counterparts who manage screening programs for Australia, Canada, New Zealand, and the United Kingdom. And we looked at several years worth of data on arrivals to our countries and the birth country for patients that we diagnosed with tuberculosis within each of our countries. And the results are fascinating, showing in these two bar graphs side by side that there is tremendous overlap in who these 5 countries receive. And we can see that as a group, in the graph on the right, what some of the largest source countries are and how we share that. India, Philippines, China, Vietnam are shared as very important countries for tuberculosis for all the countries. Mexico being the leading source of TB cases for the United States. We're a little bit of an outlier in that, as compared to these countries, Mexico is a big source for us, but not others. But then we pick up with other countries that we all share in common. In thinking about our program, as many of you know, through the years, we've had changes in moving from different types of strategies overseas and different algorithms. And the information on this slide is something that helps get into one of the big reasons we made some changes. This looks at arrivals from the overseas screening process to the United States from 1999 to 2005, when the basis of our screening program overseas was sputum smears for persons suspected of having TB. And the major take-home message is down at the bottom under U.S. TB diagnosis, that if someone overseas had an X-ray suggestive of findings of active TB, 7% of those people were diagnosed with active TB after arrival to the United States. 2% were diagnosed with active TB if they had X-ray findings that at that time were considered to be more suggestive of, inactive TB. It's actually about 4.2% altogether if you ever have a chance to look at the data in the study. We did a study in the early 2000s that looked at our screening program in Vietnam, one of our largest around the world, and incorporated cultures into the mix so that we could help determine what could be the potential increase in diagnoses overseas if we used cultures. And what we found is that by only using sputum smears, we were only finding 34.4% of the cases of active TB. So showing that we could double our diagnoses of active TB overseas if we incorporated cultures. In taking these information together and applying them to our technical instructions, and this is for the overseas instructions, we made some big changes. This is a slide just showing the schematic of that algorithm, but in a nutshell, we went to a system where if you had an abnormal X-ray, HIV, or signs and symptoms of tuberculosis, you were required to provide 3 sputum specimens for smear and culture, and then go from there with respect to your algorithm. And what we're going to show some data in a little bit on what the effect of that has been. I want to highlight the upper left-hand corner for a second. We're going to talk about some recently released updates to these technical instructions. We do have, for children 2 through 14 years of age, where the TB rate is at least 20 per 100,000 or greater, a requirement for an IGRA test as their entry point into screening. For a few years, we'll talk more in a second, we had the the option of a skin test or IGRA, and just recently moved over to IGRA. But more to come on that later on in the presentation. This is a map of where all the panel sites are around the world. We've got screening operations in over 159 countries and in over 350 clinics where these exams are performed. Once we made those changes several years ago, we worked very hard to implement these around the world. We initially targeted large volume, high burden countries, but ultimately rolled it out everywhere. Because in country, a lot of places may not have the culture capabilities and treatment capabilities we were striving for, we worked very hard in country. Particularly the panel physicians themselves worked extremely hard to develop these capabilities, and we have tried to do this with an eye towards being able to link some of these efforts with broader control efforts, essentially to have these capabilities to be able to apply for more than just US-bound populations. So now we're going to show some maps of how this was implemented over time. The first programs to get going were actually in 2007, highlighted by the Philippines and Mexico. And so now we can see every year we started getting more and more places, gained some traction, exploded in 12 and 13. And by the end of fiscal year 2013, we were done. We were able to have it implemented everywhere, but in some places that don't have screening, essentially. And so this was very exciting and very important for our program. Hopefully, you are excited also. Through all of that, I mentioned the capacities developed overseas. In working with the other countries, we published a paper a year ago that highlighted some of those examples. And this is a map from that article trying to highlight some of the many countries where we know that ourselves, the other countries, the panel physicians, other groups may have developed new laboratories, expanded their laboratories, developed second-line drug susceptibility testing capabilities, and really did some great things working with, the national TB programs. And we highlight a lot of great examples. These can range from a public-private partnership in the Dominican Republic to co-treating TB patients in Kenya, to sharing data in other parts of the world, assisting with second-line drug importation in Vietnam. Many, many wonderful examples of how panel physicians have really worked incredibly hard and achieved a ton, but also where we're able to do things for other populations in those countries. So how have we done? This is some data that is hot off the press. One of the things that we do and that the panel physicians do a great job with, and it's not easy, is we collect something we call TB indicators, which are some basic TB statistics from panel sites each year, trying to learn more about the volumes of people that they examine, the number that they diagnose with tuberculosis and any drug resistance. So for 2017, we've just tallied all of that and got the information in and got it organized. Panel physicians around the world diagnosed 1,191 TB cases overseas. 1,005 of them were culture positive. Of the culture positive cases, 80% were smear negative, but culture positive. So in the old days, basically 800 cases could have remained undiagnosed overseas had we not been doing cultures. This slide gives you a perspective of some of the volumes of some of our largest source countries. The TB rate from the panel site screening is over there on the right. And in the middle are rates of TB in those countries reported by the World Health Organization. In many countries, we may find rates of TB that are a little higher, most dramatic on this slide for Philippines and Vietnam. Some were kind of right at it, and some may be a little lower, but it's, and you can see that we definitely are finding drug resistance overseas. So we're finding cases. Have we seen that translate into gains domestically? This slide is from a study that we published 3 years ago now that looks at TB cases diagnosed in the United States among the foreign-born that were diagnosed within 1 year of arrival. And the top line are those cases. The bottom line are the smear negative but culture positive cases diagnosed overseas during the time frame of our implementation. And so we can see very elegantly and excitingly As the number of cases in the bottom in the green increased, the number of foreign-born cases diagnosed within 1 year of arrival to the United States decreased. If you add all this up together, the numbers come out almost exactly the same, which is very, very exciting to see that an intervention we did overseas was able to translate in some improvements in TB care and prevention stateside. All right, well, let's turn our attention now to the panel physician technical instructions that were recently updated and went into effect, and highlight one of the big changes and show some information as to how we arrived at that. So for this update that was just released, we had some goals really for both. We did the civil surgeon and the panel physician ones together. We wanted to define the requirements for the TB components, clarify points of confusion, address newer technologies that are available to screening physicians, and important for our division behind the scenes, we wanted to keep the format modern and consistent with some CDC requirements for how material has to be on our website and the like. We undertook a process for revision. Dr. Joanna Reagan led this revision. We received input from what we called a TBTI working group, which had representation from the National Tuberculosis Controllers Association, the Advisory Council for the Elimination of Tuberculosis, Stop TB USA, CDC's Division of Tuberculosis Elimination, and then I was on it from our division as well. And we also got input from the International Panel Physicians Association, which is a network for panel physicians, allowing them opportunities to network with one another, communicate. They're a major partner for us and put on a huge yearly training event overseas called the International Panel Physicians Training Summit. So let's zero in on the IGRA test, because this ended up being the biggest change in the panel physician technical instructions. As I mentioned earlier, from 2007 to 2018, we had this requirement that if you were 2 through 14 years of age in a country where the TB rate is 20 per 100,000 or greater, you had to get a skin test. Starting in 2009, it was either a skin test or an IGRA test. And panel physicians had the option of either test. And it's been fascinating from our perspective to see how this test has evolved over time, or more specifically, the use of it has evolved over time. We allow any quantiferon test or T-spot. Occasionally we get asked about other preparations. We only allow the FDA approved test, so that means we do not allow in-country tests that are not approved by the FDA. So during that time period, we allowed either test. This is what was happening overseas. For a couple years, the countries in pink are the ones that did have some panel physicians using an IGRA test. And we can see it's not a lot of countries, but that's okay because we were giving them the option of both tests. But stateside, as many of you are aware, much closer to this on a U.S. clinical on-the-ground level, the recommendations regarding IGRA have really swung in favor of IGRA over skin testing. For example, the 2017 DTBE recommendations say to use an IGRA instead of a skin test among those who are likely to be infected, have a lower intermediate risk of disease progression. It's been decided that testing for latent TB is warranted and may have a history of BCG. I think most people can really readily appreciate that. Our population being screened overseas typically has a BCG vaccination, definitely intermediate risk if we're looking at those cutoffs for rates within countries. So this is really getting at our population. And as many of you also know, the American Academy of Pediatrics also has really come out more in favor of IGRA, even down to children 2 years of age. So we also looked at some data stateside. So when people come from overseas, and we're going to talk later on about the process for getting information to health departments, the health departments will get the children in who may have been diagnosed with LTBI overseas through the exam, and we saw some fascinating information. From a sample, looking at over a several year period, we found that of those arriving who had a skin test overseas that was positive and a normal x-ray, 53% of them were being retested after arrival. And we saw that if a skin test was used overseas and retested stateside with IGRA, 69% were IGRA negative. So, and finally, if IGRA was used in the test stateside and was positive, we see higher rates of these children being started on LTBI treatment than if a skin test was used. This was really powerful information for us. We really, as a program, desire that if we do a test overseas, that it would, quote, count stateside, meaning the hope is if we do one of these tests in these children overseas, that when they come to the United States, the receiving programs could act on those results and not feel like they have to repeat those tests and move forward. So we really feel bad about the high rate of repeat. Certainly that is extra expense, it's extra hassle, extra anxiety for these folks when they first come. We also really feel bad about the fact that, you know, if the guidelines are moving in favor of one test and we see the conventional wisdom of the IGRA test having greater specificity than skin test, and we see that play out, and they're going to be put on treatment at a greater rate, very powerful for us to really look at making the change in favor of IGRA testing overseas. So with all of that, we did make that change, and it went into effect October 1st for panel physicians overseas, that whenever a TST or IGRA was previously required, the IGRA must now be performed if it is licensed for use in the country of examination. And we know that through all this process, we were aware we were going to be making this change well before October 1st. So a lot of panel physicians had a heads up, and we've been hearing great things about their efforts to be able to do this, and we're very excited to see how this will play out in the post-arrival evaluations in years to come. Now let's turn our attention to the other technical instructions, those for the civil surgeons. These are for the people who are adjusting their status. They have been living in the United States for at least 1 year, typically as an international worker or student, and then apply to become a lawful permanent resident. So these technical instructions really underwent a major revision, trying to bring them more in line with not only format, we wanted the language where it could to match the language in the panel physician technical instructions, and we really did a lot of work. And as many of you know, we have really been doing a lot of work since they went into effect, as these really have some changes we're going to highlight in a second that are very different. But we really appreciate everyone looking at these, and for folks in the audience who may be civil surgeons or with health departments, we really appreciate all your efforts and really appreciate hearing from you as we learn together regarding the ramifications of all these changes. So those technical instructions were last updated in October of 2009. Similarly to panel physicians, there was an option to use either an IGRA or a skin test for everyone 2 years of older. Everyone may be aware that for the civil surgeon instructions, the algorithm is slightly different. We start in the United States. If you're 2 and up, you get a skin test or IGRA, and that is your entry point to continue on with an X-ray or sputum testing. So, effective October 1st, for the reasons we went over for the panel physicians applied here, for the civil surgeons, we've now also made the switch where they will be using an IGRA instead of a skin test for all of those folks. We did a couple other things, though, and this is one of the things that is new and different. Overseas, the panel physicians bear enormous responsibility for this medical examination. They are responsible for it, and they are held accountable for it from CDC and from the U.S. embassies that work very closely with them as well. The civil surgeons, over the past few years, with some of our technical instruction updates, we have been trying to move in that direction for that civil surgeon to be responsible for that exam and really view the exam in its entirety and work on behalf of that applicant to get everything done and to really own it and own the process. In these technical instructions, we have the following sentence. Civil surgeons must not refer applicants to a health department for IGRA testing or chest X-ray. All IGRA and chest X-ray tests ordered by civil surgeons must be performed independently of a health department. This is a big change. What it means is we got a lot of feedback from health departments of civil surgeons having an applicant, and a few months ago if it was a skin test or if some were doing an IGRA, and they would just send someone to the health department to get their skin test or IGRA, and if it was positive, just send them to the health department to get an X-ray. But we got a lot of feedback that we needed to do some things to help ensure adequate public health resources, health department resources. So we moved in this direction for the civil surgeon to be responsible for getting that IGRA and getting that chest X-ray, independent of the health department. Then, if we continue with latent TB, if those are positive, or if someone has latent TB, we spend a lot of time on latent TB in these instructions, to then give that information to the health department when it was ready, if someone has latent TB. In our previous technical instructions, we had language that was just recommended civil surgeons report cases of latent TB to health departments. And through the years, we got a lot of feedback from health departments that they felt like this wasn't happening. And as we all know, for the United States or for the Division of TB Elimination, there's widespread recognition and touting that if we want to eliminate tuberculosis in the United States, we've somehow got to grapple with and try to address the reservoir of LTBI in populations living in the United States who were not born in the United States. So through lots of discussions with the working group and behind the scenes discussions with our Office of General Counsel and speaking with USCIS's lawyers as well, all of that came together to come up with the new technical instructions that say that civil surgeons must report LTBI cases to the health department. Now, the medical exam is finished at that point. Our regulations we mentioned earlier in the presentation deal with infectious or active TB. So the exam is done. The person is going to adjust their status regardless of what happens with latent TB. But we, in our effort to try to figure out how we don't miss this opportunity of trying to get treatment offered for and arranged for this group, we have the civil surgeons report, and in the reporting, they give the laboratory IGRA result and the report for the X-ray. This is a major change. It certainly is making civil surgeons and health departments and CDC, both divisions, be much more engaged and in tune and listening and trying to work with multiple folks on this. We recommend health departments decide how they would like reporting to work. Different health departments may want it done differently. Simultaneously, we encourage civil surgeons and health departments to proactively communicate with each other then on that reporting. We understand that in different jurisdictions, how latent TB is managed and treated can vary. We know that there are some health departments that do it stem to stern, and they will take care of everything and treat them. We know there are others that may have a network of private physicians that they use for services, and we know there are others that may have lower resources, and this is a really major change. We understand that, but we really worked hard and strove to strike there being something to help create the handoff of information and to create the opportunities, and are really, really supportive of anything health departments can do once that handoff is made, in the hopes that we're able to capitalize on this opportunity. But we definitely understand folks' circumstances can vary, and it will be very interesting to see how this all turns out and how things get arranged over time. But we really appreciate for the civil surgeons and health departments on all of your effort on this, working on these new instructions and working these issues out. We can't thank you enough. So now let's talk about EDN. This is the way that health departments get information on the overseas exam. What is EDN? It is an electronic system to fulfill our regulatory responsibility to provide information to receiving health departments of arriving aliens. It comes from our reg language with notifiable conditions. This is what was highlighted in that Refugee Act of 1980. This is where that comes from. For those of you who may be working with these populations for a while, this replaced an older paper-based system. It gives health departments access to the paperwork completed by panel physicians overseas, which are known as DS forms, and gives health departments an electronic system to record the outcomes of the evaluation stateside back into the system, and it's managed by the branch I'm in. Here's a flow showing how this goes. And so you have the overseas screening by panel physicians, the forms they fill out. Those folks come to the United States. There is an elaborate two-step behind the scenes between personnel at U.S. quarantine stations and Customs and Border Protection to get records from those who had a TB condition overseas or any other Class B condition for the other diseases, to hand those over to the quarantine stations. They ship them down to Atlanta, where we do data entry. It goes out to the health departments through the EDN system, and when there are evaluations and results entered back in, that comes back to us. For refugees, there's the little arrow at the top, the EDN IOM interface. For all refugees, there is an electronic interface with IOM, the International Organization for Migration. IOM does a portion of the exams on refugees overseas, but behind the scenes manages and coordinates their travel, whether they were examined by an IOM physician or not. We get the results of the exam through their system for routing that information for resettlement. So for EDN, health departments and quarantine stations contact our branch with problems or to request additional information. We then have direct contact with panel physicians and consular sections overseas. And health departments can also notify us on medical packages that need immediate follow-up. So let's talk about eMedical. This is an exciting new frontier for us. eMedical is what we've all dreamed of and worked toward for so long. It is a web-based electronic health processing system. It was originally developed by the Australian Department of Home Affairs to be used by the panel physicians for Australia for their exams. It's used by over 750 panel physicians around the world. It's currently used by Australia, Canada, New Zealand, and soon en masse by the U.S. government. eMedical eliminates the need for panel physicians that are screening for more than one country to have to use multiple systems. The data will be transmitted electronically from eMedical through something we call pre-med into EDN. eMedical is not replacing EDN, is not a CDC application, is live, and we're going to talk about a pilot that just began. eMedical initially will only be immigrant visa applicants, so not refugees, and will not be 100% paperless immediately after implementation. Okay, here's the schematic we saw earlier with eMedical inserted. So basically, at the top, you still have the IOM EDN interface for refugees. At the bottom, for immigrants, eMedical, the results of that examination will go into what we call our pre-med database. I think of that as like a holding cell until someone arrives in the United States. We will have a signal from CBP that they have arrived, and then the record will go into EDN and out to the receiving health departments. One exciting feature that I am personally so excited about, panel physicians will be able to upload a DICOM digital chest x-ray image into eMedical and have that routed through these systems and be available for the health departments. This will hopefully be able to get us out of the burning CDs, giving CDs to applicants, risking applicants losing them, risking applicants getting confused, and giving them to an embassy or to CBP and have them available when they come for follow-up. We really hope this can streamline that whole system, and for those of you who work at health departments, have those x-ray images available to you when you see somebody. We began a pilot in September for exams in 3 countries, Australia, Canada, and Ethiopia. This pilot is really small, really targeted to test the flow of electrons, the systems, how they are working. So it is extremely small, extremely limited, but so far, so good overall. We're definitely learning a lot and in constant communication with our colleagues in Australia, their IT engineers we've been working with Department of State folks, with panel physicians. So we are really eager to really go big. We would love to have this in place around the world tomorrow if we could, but it has started, and hopefully this pilot will continue to go well, and we can very soon expand, and we will definitely keep local health departments informed of that progress, especially once it starts going big time. Okay, just a couple last final slides. Panel physicians are civil surgeon and panel physician technical instructions are at the following links on our webpage. I know you've got some resources through the webinar system. Finally, I'd like to acknowledge some of the many people, there's too many names to mention, who've been a part of working on this and helping make those things that are successful as they are. All right, and with that, I am more than happy to answer any questions you may have.
Dr. Posey, this is Connie Haley. I want to thank you for being our speaker today. That was a wonderful presentation of the system, I think, helps shed some light on what's happening behind the scenes, and also hopefully our audience will have a better feel for how the patients that are being seen in their clinics are being evaluated overseas and also treated where appropriate prior to coming over. You've been working at this for quite a long time, so I wanted to ask you a couple of questions. And one, I guess, is how would you want to describe the overall benefit that this is going to have for us here in TB elimination? There's always a little bit of controversy about money being spent overseas and versus the needs here in the U.S. So I really wanted to give you an opportunity to speak to how significant this is to help reduce the work and the resources that are going to be needed by our local health departments.
All right, great, fantastic question. There's something that I made a mistake on earlier, and it was an omission and just glossed over that may tie into some of that. I had a picture of a study that I forgot to mention the study as I charged into talking about capacity development overseas. There was a study that came out several years ago that said if the United States government were to compare tweaking its screening programs versus investing in TB control overseas, we get a greater return on the investment if we invest in TB control in source populations and source countries overseas. So I think that informs two levels for us. One, I think our experience has shown that by increasing diagnoses in the screening program, we can get a lot of people treated for TB overseas. That translates into removing a lot of cases from being diagnosed and having to be treated in the U.S., and that there are cost savings for that for, the U.S. healthcare system or health department budgets in general, depending on how all the financing works. We actually did a cost effectiveness analysis looking at our screening program for the Philippines and found that moving a lot of these things overseas definitely bears that out for hospitalization and health department costs stateside. But I do believe the more we can try to do novel things with working in source populations overseas, if we can reduce the burden or somehow even just contribute, we're not going to eliminate TB globally through an immigration screening program. But if we are keen to have the state-of-the-art facilities that so many panel physicians around the world have worked so hard to develop to be able to benefit their local populations, and their burdens can go down a little bit, that takes pressure off some of the panel physician exam to find all those cases, and then that should also lead to fewer cases stateside again. I think it's a great question, and it's one that we think about and struggle with, but I do believe diagnosing and treating these cases overseas, having an eye towards working in source populations, does help save resources that can be used in other areas within the United States.
I'll just add to that, as a medical consultant for one of the Centers of Excellence, we do assist in providing guidance to overseas panel physicians who are treating patients diagnosed with drug resistance so that they get appropriate treatment overseas. So I would imagine that by diagnosing and treating individuals with multi-drug resistance, pre-XDR, and even XDR prior to their arrival in the United States, that's really removing the significant cost of just even one of those being somewhere from $250,000 to $500,000 that a local public health department will not face if that patient is found and treated before they come over. Is that correct?
Yes.
Great. And would you also answer one more question for me? And I do see we've got some great questions from some of our audience. I'm really excited that you're starting to do some screening overseas even for TB infection with the IGRAs. And I was talking at our clinical course this week that sometimes the hardest thing for us to do in public health is to not do something. And so since these IGRAs are being done overseas, would you say that that quality is sufficient so that when a patient is presenting, or an immigrant or refugee is presenting to a local health department with an IGRA result that shows that it's negative, that they can generally feel comfortable accepting that result and not feeling like they have to repeat that, as they might, even though you have a chest x-ray from overseas, many of those individuals will get chest x-rays again in these health departments. So could you speak somewhat to the quality and comfort that people can have, and also what the requirements will be in the paperwork that you're expecting them to complete for their evaluation? I'm assuming you won't require them to do the IGRA again if it's already been done overseas.
Okay, great. I personally feel really, really comfortable with the quality of our laboratories overseas. We, through this work, if we just think about the culture laboratories, they've really done some fantastic work, a lot of great capabilities, and we do a lot to help oversee laboratory efforts within our program. We actually have a laboratorian on our team named Sean Toney, who spent many years doing international lab work at the Division of TB Elimination. We also, for many years, have had the benefit of using a laboratorian that many of you have heard of named Warren Jones, who's with the International Organization for Migration. And between Warren Jones and Sean Toney, there are many laboratories visited every year. And Warren Jones visits not just laboratories with IOM. We're able to take advantage of his expertise globally. So we have a large number of laboratories visited every year by these folks who do a fantastic job working within the lab with the technicians, going over everything. They have expertise in the IGRA tests, not just the smear and culture capabilities. And so we feel really good that as panel physicians add these capabilities, they're frequently adding them on in laboratories that are already doing an excellent job with smears and cultures. I think the key there is meaning they are in laboratories where the personnel are highly trained, they've got good procedures, and so even though it is a different test, it's personnel who are accustomed to concepts of proficiency, having good standard operating procedures, doing things right, basically, gives a lot of confidence. On top of the visits that we do, we feel really confident that we can pull this off and that panel physicians can pull this off. And so we hope that those results, when they come stateside, people feel good about them. Now, having said all that, we do these visits because we are talking about large numbers of people. But what we do, I want to provide some reassurance that we definitely have in our program a robust laboratory wing, if you will, and know that we're going to be very active on the IGRA front and already are to help ensure that everyone's doing great and we can feel good about the quality. With any laboratory test, there's going to be things that happen. There are going to be with cultures, it's one of the most difficult things because you're fine-tuning, getting the results that you want. IGRAs have the challenge of there is going to be a certain percentage that have borderline or indeterminate results. And so looking at that ratio is something that we'll be looking at, just like we look now in cultures at this ratio between smears and culture positive, and some other data. So we're going to work really hard. What I do hope, provide reassurance, is when people get those results stateside, we are asking the panel physicians to include in the packet the printout of the laboratory result, which is, so many of you on the phone know more than I do. For IGRA results, particularly quantiferon, you want to see the breakdown of the null value and everything. So our intent is to give that so that you could have the full printout, and hopefully we can lessen some of the automatic retesting. I'm sure there will be some sorting out and some confidence being developed. And if there are any problems that do arise, we will certainly jump on those right away. Thank you.
Thank you so much. I do see that several of our audience were asking about whether or not the actual quantitative values would be provided. So it sounds like you will be providing through the eMedical not just a positive negative result, but also the ability to look at the mitogen or positive control, the actual TB minus nil value, so they can determine how positive it is, and they can use those data with their clinical assessment to make good decisions about treatment. There's another question here about whether or not patients who have indeterminate IGRAs will be retested overseas, or if they'll just get the one test and those would need to be retested on the US side.
Great question. It'll actually be the latter. If someone has an indeterminate result overseas, we are not going to require retesting. They'll be able to continue on in the program or through their exam. They won't be retested or be required to have an X-ray in the absence of other, clinical findings warranting an X-ray.
Wonderful. I see a note here that one of your civils or one of your panel physicians would like also for you to inform the audience that the medical examinations performed by panel physicians are paid by the applicants themselves. So some of that cost is not just the U.S. government. It also, the applicants actually do participate in the cost. Is that correct?
It is correct. Great point. I'm glad that came up. Yes, the immigrants pay the cost of their own examination. The exam for refugees, though, is paid for by the U.S. government through the Department of State and how they work to resettle refugees. But excellent point that came up.
One of the other participants asked another question specific to refugees. If the panel physicians are not using eMedical for refugees, does that mean that the chest X-ray images will be available in the EDN only for immigrants, or can you also get the X-rays for refugees there?
Right now, that interface does not have the capability of transmitting the X-rays electronically into EDN, but it is something that we would like to develop that capability as well. But it's probably going to follow eMedical in timing.
I was speaking at a conference recently, and someone brought up an issue that I think was more of a problem in the past, and that was fraud with regards to chest X-rays, where someone might present with an X-ray that was not their own in order to be considered clear for immigration. And would you address that? And would you also address that the people making the determination about who gets to immigrate or not are not the panel physicians, but rather someone at the consulate? Do I have that correct?
So two great things. Yes, we can talk about both of those. Fraud is something that the State Department, the panel physicians, and CDC are all very appreciative of and try to do things to limit opportunities for fraud. One of those is by having panel physicians, meaning we if you're immigrating to the United States, there's only a few places you can go to get your exam, as one example of trying to zero in on and make sure, not just from a quality of the exam standpoint, but it is a fraud reduction measure also to have a limited or specific number of clinics and services to use. And then within that physician setup, everything that they can use is likewise limited to help eliminate opportunities for people to try to do something. X-ray fraud, historically, yes, it certainly has happened, and when we've ever been made aware of it or are colleagues at the embassies have been made aware of it. It's been dealt with swiftly to remove those opportunities from the system. One thing that I hope, excuse me, is that we now require digital x-rays to be used. And I think there's a little bit of a hope that by using digital systems, it makes it harder for someone to bring a film, because now you've got a digital file with information about that person entered into the record. We require at every step of the process in the panel physician exam that their identification be checked and compared with their passport, or if it's a refugee, other approved identification. And that's, when someone shows up at a panel site, when they get their exam, when blood is drawn, when they get their x-ray, when sputum is collected, always checking their identification, comparing it with the person in front of you, and the like. We work very hard to be rigorous on that to help eliminate opportunities for fraud to creep in. So it's something we're always vigilant about, and the panel sites are hyper vigilant about. For the second point, you bring up a fantastic point that is definitely worth going over. And you're correct. CDC does not have any say in determining who comes into the United States. Our role is to make sure that those for whom an exam is required, they get the highest quality, best exam they can get. Determinations of who enters the country, I guess, are really made, through Congress or through the refugee determination each year, and administered by the Department of State and Departments of Homeland Security. And then we're just the medical exam piece in that overall process. And that's true for immigrants, refugees, the non-immigrants coming to the United States. We have no say in who comes. They're not routinely required to be examined. But you're right. Those decisions happen basically in Washington and with the Departments of State and Homeland Security, independent of CDC. And we just try to make sure for whoever gets an exam, they're getting the best one they can.
That's wonderful. There's a question here from a participant asking about handwritten data that's been traditionally on forms, as well as missing data. Could you speak to how changes are being made that may overcome some of these challenges that people are facing now?
So as it relates to handwritten forms, we do require now for the DS forms to be typed. And so if health departments are seeing forms that are handwritten, definitely let us know, and we will follow up with the panel physicians overseas. And if someone sees examples of forms that they don't understand something, meaning they think the panel physician may have done something wrong, definitely feel free to reach out to us, and we'll see what we can do and take a look as well. And if we need to follow up and help give some pointers, we're more than happy and interested in doing that. We hope that with the e-medical system in the future, because it is an electronic web-based system, we hope that will be good as it relates to helping with some of those issues. The e-medical system, the US module, has a lot of internal validity checks built in, such that if a panel physician is entering in the results of the exam and say they enter in that the X-ray has a finding that warrants sputum collection, the e-medical system is set up in such a way that the panel physician will not be able to submit that record until the sputum specimens are entered. So we're hoping some of those behind the scenes internal validity checks will also help address if ever someone sees some mistakes. Having said all that, I do want to point out panel physicians overseas, combined for immigrants and refugees, are examining over 600,000 people per year. And so, you know, we're going to find mistakes, and that's okay. They're doing a great job. It's hard to be perfect. But when we see things that are really confusing, really squirrely, don't look like, wow, I think they really meant that, but that's okay. We see what they're getting at. Let us know. Or if you see a trend, definitely let us know, and we'll work to look at that and follow up overseas.
Dr. Posey, I know from working with you that you and your team are very generous with your willingness to help. Can you, when you say reach out and let us know, it sounds like you're talking about both from individual patients that come in and also general system things that may help you all continue to improve the quality of your program. How specifically would you like them to reach out to you? Is the phone number at the end of the presentation the right way to reach you? And then one more question would be, what calls are appropriate to come to your team, and what calls would you say are appropriate to come to a Centers of Excellence that can help with some of the clinical aspects of taking care of these patients?
Great question. For what you see on the screen is the CDC public inquiry line. Someone can always do that, and it'll rattle down to us, but I think for health departments, seeing someone who's arrived, got questions about the medical records, you can feel free to reach out to me. I know many of you know some of the others on our staff. You can reach out directly to them as well. And that's fine. That's, you know, if when there are issues, we definitely like to know about them so that we can address them best we can. And I think you had a second part to your question.
The second part to my question was, what topics are better
yes,
that should come to you versus the Center of Excellence?
Great. Sorry, I forgot about that. So the Centers of Excellence, if your question is not dealing with the information you're getting from the panel physician or through EDN, but now you're thinking through how you're going to manage them. So whatever information is available, you've got, but now you're making clinical decisions, trying to sort out, do I treat this person for active TB or not? Do I treat this person for latent TB or not? What do I make sense of the available results, and what additional tests, if any, should I do? I feel like those are perfect for the Centers of Excellence. Our group works hard to get these exams done, works on the instructions, works with panel physicians, but then once they are here and they're getting evaluated and you've got all the information that we can provide you or that is available, I feel like from that point forward on making clinical decisions, that's when the Centers of Excellence come in.
That sounds super. And we, I know that SNTC, but also our other Centers of Excellence as well, are all very happy to take calls on any topic related to TB or TB infection. So please do call us for any patient assistance or programmatic concerns. I've got a number of other questions. We might want to go a little faster through some of these. One is asking, now that we have new overseas TB screening guideline or technical instructions, should we expect any updated domestic TB screening guidelines for refugees to go along with these newer recommendations?
Fantastic question, and the answer is yes. In our branch, we have what we call the domestic team, which one of the things they do, which is on our website, are some post-arrival domestic refugee health guidelines. And now that we have made some changes to the overseas screening exam, they are looking at their guidelines for post-arrival refugee examinations for tuberculosis and comparing and looking at where, if any, changes they might need to make, to keep everything in sync with one another. Excuse me, and that's something they are doing, so I anticipate it at some point in the future. I'm not really involved with that effort, but I know they're working on it, and at some point we can expect an update to the domestic refugee health guidelines for tuberculosis.
Wonderful. Another question is, with the IGRAs now being recommended for all the way down to the age of 2, someone is asking, do we still do tuberculin skin tests for children under 2 years of age? And I believe the answer is yes.
I think that's what's probably going to happen. Everyone can use, when you get in those situations, their clinical judgment, but I anticipate that panel physicians will be doing skin tests if they have to do more investigations in that age group.
And then another question we have related to the use of IGRAs is, do you anticipate that adults might be screened overseas for latent TB infection with IGRAs?
I think it's an excellent question. I think it's something that we definitely think about and discuss, and we did consider for this change, and then the decision was made for right now. We would just leave it moving to IGRA where we were already doing IGRA, but it is something that we think about and talk about, and we'll see what the future holds. But it is something that is a topic of conversation and thinking about what and how that could look. But for right now, we're doing IGRA where it was being used in the older instructions.
This is probably a good time to draw the audience's attention to the handouts. If you will look in your control panel, you'll see that we have 3 handouts for today. One of them is a PDF of the PowerPoint that Dr. Posey presented today. There are a few slides that were taken out because it relates to internal data that has not yet been published. The other is the CDC announcement that includes instructions that outline the new technical instructions overseas and provide a link for you all to know how to go get the more detailed information. And then Dr. Posey, would you like to talk briefly about the third handout, which is the PTOP study that has to do with screening and using 3HP in individuals as a pilot study? Sure.
So in our screening program in Vietnam, and carrying the tradition of having used them for studies in the past, ourselves and our division, and also the division of TB Elimination and the international branch and the division of global HIV and TB control, have recently started a study in Vietnam, which is a feasibility study, very limited, small number of persons, where they are offered an IGRA test, and if that IGRA test is positive and they have latent TB, so meaning a negative X-ray, they are offered voluntary treatment for latent TB before departure using the 3HP regimen. That got going 1 or 2 months ago, and so far it is going well with being able to have people enrolled. In addition to the overseas component within Vietnam to offer testing and begin treatment, there is also a stateside component to be able to follow these folks and utilizing the EDM system so that we can one day look at this data and gauge the interest and uptake and lessons learned from trying to take that type of approach and see what that data shows and what it may inform our program or not inform our program as the years move on.
Thank you for sharing that information. One other question that I had as you were speaking is, I think it's really exciting that the civil surgeons here in the United States are going to be doing some of the screening and also not just the IGRAs, but also going on and doing chest x-rays for those with positive test results, and hopefully doing a good clinical exam to rule out active TB or rule in active TB before referring those individuals to the health department. With the new, well, not new, but with the continued emphasis on trying to expand identification and treatment of latent TB, and to spread some of that effort out among community providers and others. The new U.S. Preventive Services Task Force recommendations, were added as well to kind of encourage others in the community to assist us with treatment. Is it possible that civil surgeons might begin to assist not only with evaluation and diagnosis, but also with treatment of LTBI?
Sure, and so there may be civil surgeons that do, and they certainly could. The aspect that we have to sort of maneuver through is the fact that latent TB is not what we call one of these inadmissible conditions into the United States, meaning that an applicant either overseas or for status adjustment that is diagnosed with latent TB does not have to be treated for that condition as a requirement for immigration. Excuse me. So that means that any civil surgeon who wants to take on offering treatment is really making that offer then as a physician separate from their required duties as a civil surgeon. So one, it may be curious to see if these folks are civil surgeons seeing the applicants. There might be health departments who try to go that route and work with them, and they offer treatment, but that treatment would be offered sort of after the exam is completed and after their duties as a civil surgeon are fulfilled to conduct that exam. We'll see if there are health departments and civil surgeons that go that route. But so long as LTBI is not an inadmissible condition, it wouldn't be as a visa requirement, and civil surgeons would be in the realm of an extra resource that maybe someone would try to utilize and coordinate with, separate or in addition to their regular civil surgeon duties.
Thank you. I've got one more question. Someone is asking, is it wrong to do IGRA on children younger than 2 years old?
Oh, that is probably beyond the scope of what I could provide. We've got a team that folks on it, I feel, have a tremendous amount of tuberculosis expertise, but admittedly, when it comes to IGRA tests in children, we have to hit the books and talk to the experts, talk to people at DTBE, we talk to people at health departments, we talk to some of the leading pediatricians in the TB world to get their input, and we look at what guidelines are out there. And just to be honest, I don't think I have the pediatric TB expertise to really be able to answer, could or should IGRAs be used in children less than 2. I'm at the level of, as we work on this is how our program comes together and what we're trying to do.
I'll jump in. I have to say I'm not a pediatrician myself. My understanding is that there's just not enough data as to whether those tests are fully accurate in that younger population, as the immune system is not fully developed. But I don't think that it's wrong. And my understanding is some providers do IGRAs on children younger than 2 years of age. It's just the question would be whether or not a negative result truly rules out infection. But I think there's, like you said, there's more to come on that topic. So I believe we're done with most of these questions. I want to let everyone know that this webinar today is part of our larger series of When TB is the Least of Their Worries. It will be recorded and put on our website at SNTC, and the handout will remain available as well. And I want to make everyone aware that our next webinar is going to be related to this one. We'll be talking about TB specifically in refugees. Dr. Susan Cookson and Dr. Susan Maloney, also from CDC, will be our speakers, and that will occur in January, I believe January 22nd. I would like to thank Dr. Posey again for an absolutely amazing webinar, and I want to thank all of our participants for so many good questions. I think that there was so much information that came out of the question and answers. That was almost as valuable as the greater presentation. So, Dr. Posey, do you have any last words that you'd like to say in closing?
Just to thank you all for the opportunity to be able to share this information, and definitely feel free to reach out if you've got any questions. Great.
And if individuals were to send us questions through this webinar after we're done, or send it to SNTC, could we pass some of those on to you?
Absolutely.
Okay. Thank you all for participating. I hope that you enjoyed this.